Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article number 2. Welcome to the Pain is Not the Only Problem podcast. The essentiality of conservative care is being reevaluated. The contributors to patient symptoms are being re-explored. All options are on the table. Article 2. Pain is not the only problem. First encounter. These articles intend to 1. Reevaluate the prevailing clinical practices thought to manage low back pain. 2. Submit and debate novel low back pain contributors and mechanisms. 3. Meet patient satisfaction, expectations, and clinically meaningful results. 4. Recommend a conservative non-surgical course of care to override pain instantly. And 5. Restore ADLs and patient confidence on the first visit at low cost. When you ask the patient how they feel, they commonly respond with a physical description like, "My back feels stiff and achy," and they may point to the area of concern. They may elaborate a bit more on their own, or if the doctor inquires further, "Well, my back hurts when I play tennis." In my experience, patients that are the most frustrated and feel like their injury is causing them the greatest annoyance will automatically spell it out. "Doctor, my back hurts on this side, right here, after a few forehand strokes, and so I've given up on playing tennis altogether." Pain is an entire experience, not just discomfort. Ouch! The entire experience may include anger, sadness, lifestyle inconveniences, loss of court time with friends, worry, assigning self-blame, for example. When you ask the patient, "How does the pain make you feel?" they will respond with an emotional description instead of a forensic description. "Doctor, I'm so frustrated. I just started playing tennis. I'm not a sporty person, and this is my first try at sports. I already feel like a failure." What is the importance between the two questions? Firstly, asking both questions demonstrates that you are a caring physician and that you want to understand how the patient interprets pain. Secondly, asking both questions demonstrates that you do not manage your practice by isolating your case management to an area of the isolated complaint, but rather that you respect how the complaint is interfering with their lifestyle expectations and that the patient is an entire person. Asking both questions provides the clinician a huge advantage in diagnosing and case management, since everything they need to know is embedded in these two questions. Where does it hurt, and how does it make you feel? Case management is not just diagnosing and execution of a course of care, sometimes mistakenly called a treatment plan, or worse, a treatment. Case management implies that the patient, the entire patient, will receive professional supervised care and that the patient will be directed to care that is efficient, least time and cost, and effective, best outcomes, least risk, least side effects, and least delays, towards a return to normal daily activities and a return to athletic activities. The highest priority is to respect the patient's values, if you even bothered to ask. Medical doctors commonly practice only between what we call the brackets. However, consider all four for best practices. First, we have the patient coming in and discuss the mechanism of injury. Next, we have what's typically covered in medical practice in the brackets: diagnostic features and symptoms, close bracket. And then we have patient values. the patient experience normally be diagnostic features and symptoms. What I'm recommending is that the mechanism of injury be explored and also the patient values. In my office, after cordially greeting the patient and settling them in comfortably in the exam room, I say something like this: "Thank you for coming into my office today. I'm grateful that you have chosen to entrust me with your care. I understand from your chart notes that you have back pain the past few days since you were playing tennis, mostly when you swing your racket. Can you tell me a bit more about the problem?" In my office, I immediately demonstrate my willingness to recognize the patient is an entire patient, not just back pain residing inertly. Then I ask, "Can you tell me how the back pain makes you feel?" According to Brodall, 2017, the intensity and suffering is largely determined by what the pain means to the patient. The person's beliefs about the cause of the pain may be right or wrong. The location of the cause of the pain must be distinguished from the location of the pain itself. I love that quote. Again, Brodall, 2017. Isn't it commonplace for the clinician to stare at the site of the complaint and isolate this area from the rest of the patient's body? What are the automatic questions that you use to determine the cause, source, and explanation for patient pain? What are the automatic actions that you perform to determine the cause, source, and explanation for the patient's pain? Did you reflexively prescribe muscle relaxers, painkillers, anti-inflammatories, or refer physical therapy or epidural? Brodall's statements steer the physician understanding towards a personalized approach, a sensitive, entire approach. Then in my office, I ask, "What are your expectations of me today?" Usually the patient has no idea how to respond, so I prompt them. "I'm here to advocate for you, to help you get better as quickly as possible, and to meet your personal values regarding your preferences in care. This is your opportunity to give me my marching orders. How may I help you today?" What are patient preferences in care? Different patients have different ideas about how they want to receive care. Do not assume that every patient is okay with prescription or over-the-counter drugs or surgery. Remember, patients believe that every doctor knows everything there is to know about medicines. Doctors only prescribe the absolute best care that works 100% of the time, though doctors do not, and they can't. Low back pain is evil, elusive, and very difficult to diagnose since there are more than 200 possible contributors to be considered in isolation, the majority of which cannot be seen on imaging, according to my research, potentially giving clinicians 2 times 10 to the 114 combinations to consider. Why is it important for the clinician to order imaging, do labs, refer to neurologists, repeat imaging, and delay diagnosis when a sufficient course of care without drugs can begin today? Isn't it possible to address the patient's complaint from an entire patient platform? I call this platform the whole patient approach, the polar opposite of attempting to zero in on milligrams of tissue, pointing a pencil eraser at a disc herniation, and proclaiming a singular cause. And in truth, the disc did not herniate for no reason, so why diagnose the cause as herniation? Considering that there is an entire patient, why not ask the patient what they were doing when their pain occurs? Mopping, sitting, reaching, pulling luggage? Pain is not the only problem. The clinician must consider the patient values and ideas about pain and what it means to them. Maybe the problem is the failure to consider the entire patient. This requires more attention, but at the end of the day, clinicians are building the best possible relationship with their patients in practice and setting an example of excellence for their colleagues. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-culture willingness to strengthen medicine. Thank you.